Thank you so much. Good afternoon, dear audience. Today my talk is about polycystic ovary syndrome and its treatment with the help of regenerative medicine modalities. So this disease is multifactorial, heterogeneous, and usually these patients present with multiple symptoms, including dermatological, including reproductive problems, including psychotic, and as well as cancer, cancerogenic processes. So the most common dermatological problems that is common among the polycystic ovary syndrome patients is hirsutism, acne, alopecia, acanthosis nigricans, seborrhea also. In around 50% or up to even 80% of patients, they would present with dermatological problems. So if a doctor see these symptoms, straight away should be evaluating patient for polycystic ovary syndrome. Another name is Stein-Leventhal syndrome or Stein-Leventhal disease, in case if it's a primary and not a secondary, so without any underlying cause. It was discovered or that name was given by the doctor Stein-Leventhal in the year of 1935. So that's quite long ago this syndrome or disease was detected and distincted. So the most common characteristics is the androgen excess, is the dysregulation of ovulation or abnormal ovulation, anovulation or oligoanovulation, most common, and also polycystic ovaries. It affects up to 20% of women, but actually in real is higher, the statistics up to 25-30%, and is one of the most common endocrinological disorders among women, as well as the most common reason of the hirsutism in the clinical practice. So what are the most known causative factors or risk factors? First of all, it's a genetic predisposition. It was detected the genes that are inherited from one generation to another by the female offsprings. The one that with high chances would predispose a woman to develop a polycystic ovary syndrome during the lifetime. Nowadays, last studies revealed the epigenetic marker in the embryos, the one that those embryos that would probably have polycystic ovary syndrome during the adult life. So that matters for pre-implantation selection of embryos in the IVF technologies. So the preference would be given to those embryos who does not show this epigenetic marker. It's according to the latest studies. So among the risk factors is premature menarche, which is earlier than 10 years old, premature adrenarche, earlier than 6 years old, obesity, of course, and the insulin resistance, diabetes type 1, type 2, and gestational diabetes, metabolic syndrome, hyperandrogenism due to other reasons. For example, it's adrenal hyperplasia or Cushing syndrome, Exposure to heavy metals such as mercury and cadmium. Also, there was a studies that revealed the relation between this causative factor and occurrence of the PCOS. And of course, the stressful factor. Stress leads to imbalance of neurotransmitters in our brain, including hypothalamus, such as dopamine, aminobutyric acid, and also kisspeptin. Kisspeptin is the known hormone that regulates the pulsatile production of gonadotropin-releasing hormone. And in the root of this disease, there is an imbalance or abnormal production of gonadotropin releasing factor in the hypothalamus that leads to hyperproduction of the luteinizing hormone, of a follicle stimulating hormone. That is why when we see in the blood test ratio of LH to FSH, which is 2:1 and above, so we straight away can conclude with the polycystic ovary syndrome in those women. So stress is one of the most important causative factors. The intake of anti-epileptic drugs also can promote polycystic ovary syndrome development, such as valproate, for example. Mexican American ethnicity, so these categories, these races would be more predisposed than others to develop PCOS. The conditions that most probably would lead or will be related to PCOS development: hypothyroidism, hyperprolactinemia, hypothalamic disorders, Cushing syndrome, as already mentioned before, congenital adrenal hyperplasia, especially its non-classical form, the one that caused by the deficit of the enzymes such as 21-hydroxylase and 11-beta-hydroxylase, leading to redirect or shift in the steroidogenesis. Yesterday, maybe you remember from my previous lecture on estrogen dominance, there was a chart of steroidogenesis. So the precursor of all steroid hormones such as androgens, estrogens, mineral corticoids, and glucocorticoids are progesterone metabolites, including pregnenolone and pregnanolone. So the shift due to these two types of deficiencies is going in the androgen side. So those patients will be experiencing lack of aldosterone and lack of cortisol during their lifetime, but hyperandrogenemia, so increased production of the androgen hormones. Ovarian hypertrichosis. Hypertrichosis is a quite rare disease that usually occurs in postmenopausal women, but also menopausal can experience, which is compared to PCOS, how you can differentiate. PCOS happen usually in women, occur in women of reproductive age, but menopausal also can. So ovarian hypertrichosis is caused by the hyperproliferation of luteinized granulosa cells, the one that appear to be oversensitive to stimulus of luteinizing hormone and produce excessive amount of androgens that lead to thickening of theca and of the stroma of the ovaries, and is characterized by the severe hyperandrogenemia and virilization, coarse voice, hirsutism, acne, alopecia. So if you see postmenopausal women with these symptoms, first thought that come to your mind is ovarian hypertrichosis. This is the process of normal regulation by the steroid hormones and also pituitary hormones of the follicular genesis in the ovaries. And as I mentioned before, that all starts from the hypothalamus. Hypothalamus secretes gonadotropin-releasing hormone. Gonadotropin-releasing hormone is fast pulsatile, frequent pulsatile mode of secretion, leads to in the normal organism, not in PCOS, it stimulates pituitary to produce luteinizing and follicle stimulating hormone. Then luteinizing hormone stimulate TICA cells of the follicles in the ovaries, and out of cholesterol and then progesterone precursors, and androgen hormones are being synthesized. And later on, under follicle stimulating effects, the production of estrogen hormones is been mediated, leading to growth of follicles into antral and pre-ovulatory ovulatory. So when we have hypersecretion of the luteinizing hormone leading to androgen excess, it leads to atresia of antral follicle and multifollicular structure of the ovaries, the so-called string pearl appearance, which is quite relevant and common for the PCOS. The pathophysiology of polycystic ovary syndrome. So the exact etiology, etiological factor, or why it happens in the female body, nobody knows, and it's still unknown. But there is a, as I mentioned, genetic predisposition and lifestyle features, for example, obesity, sedentary lifestyle, so exposure to high oxidative stress, for example, factors that those women or those patients develop insulin resistance. Insulin resistance leads to high production of the insulin, and at the meantime, as I said, they also experience overproduction of luteinizing hormone in the pituitary, which stimulates the ovaries to produce more androgens. And due to high androgen production, also the enzyme aromatase, the one that's supposed to convert androgens to estrogens, also appear to be inhibited by the excess of the androgens. On the other hand, excessive production of the insulin also fuels the excess of androgens and inhibits the sexual binding hormone production in the liver, and that leads to increase of the free androgens in the blood. So 3 mechanisms of hyperandrogenemia we can observe in this case. They arrested due to high androgens, arrested antral follicles. They lead to anovulation. Of course, none of them compete and grow to pre-ovulatory, ovulatory dominant follicle. So, and also the high androgen level causes the thickening of membrane or thickening of stroma of the ovaries. So the growth of these follicles and rupture simply impossible to happen. That is why one of the treatment for PCOS is ovarian drilling done by laparoscopic surgery. Anovulation, so absence of ovulation, leads to zero progesterone production. So the estrogen that still appear to be converted out of the androgens is unopposed. That leads to endometrial hyperplasia, risk of endometrial carcinoma, as well as anovulatory bleedings. So one of the clinical symptoms that these women present is anovulatory bleedings. Of course, anovulation leads to infertility and subfertility. So this is another clinical presentation sign of these women. Among the rest, among the one I mentioned already, menstrual abnormalities such as ovulatory, anovulation, hyperandrogenism signs, hirsutism, acne, alopecia, and seborrhea, for example. Those women present with hypertension, with non-alcoholic fatty liver, hepatosteatosis, with cardiovascular disease and psychotic symptoms such as depression or anxiety. Diagnostic criteria. Since 2003, there was adopted Rotterdam criteria which remain until nowadays, with only one change in 2012. So Rotterdam criteria of the diagnostics of the polycystic ovary syndrome implies the presence of 2 out of 3 diagnostic criteria, such as hyperandrogenism, either clinical, either biochemical. So you see the high level of androgens in the blood. The irregular menstruation, so anovulation or oligo-ovulation, or we call it also oligomenorrhea. And also polycystic ovary appearance on the ultrasound of the ovaries, or MRI, for example. So presence 2 out of these 3 criteria already allows us to conclude with the PCOS diagnosis. Then in 2012, National Institute of Health updated this criteria with the distinction of 4 phenotypes. So these 4 phenotypes, for example, phenotype A, women supposed to show hyperandrogenism, ovulatory dysfunction, and polycystic ovary morphology. So all 3 criteria should be present. The rest 3 is combination of 2 diagnostic criteria. Polycystic ovarian morphology, that is how we see the multifollicular ovaries on the transvaginal ultrasound scan. So the volume of the ovary is supposed to be 10 milliliters or 10 cubic centimeters and above. The amount of follicles more than 12. And the size of them 2 to 9 millimeters, antral follicle. If you do 3D ultrasound, that's even more informative than 2D, and allows to more accurate count the amount of the follicles. And you see there, one of the signs is the string of pearls on the periphery of the ovary, so they look like a string of pearls. For adolescents, the diagnosis of PCOS can be established in the presence of all the 3 criteria, not like for adult women, 2 out of 3. So hyperandrogenism, oligo or anovulation, and polycystic ovarian morphology should be there. Hirsutism. Hirsutism is usually present in 50 to 80% of women with polycystic ovary syndrome. It's an excessive growth of terminal hair in the androgen-dependent areas. The scale of Pheromone-Galway helps to indicate hirsutism. So usually you should evaluate 9 androgenic zones of hair growth. It's a upper lip, it's a chin, chest, upper back, lower back, upper abdomen, lower abdomen, and also thighs and arms. Each area estimated from the score from the 0 to 4 scores. 0 is absence of hair, 4 is excessive hair. So in total, score 8 and above allows you to conclude with the hirsutism. Acne. Acne are supposed to be differentiated with acne vulgaris because acne vulgaris is also quite common, especially in a young population. Why acne is the one of the symptoms of PCOS? Because androgens increase the production of sebum in the glands, in the skin glands. So it causes the blockage of normal grease excretion, abnormal exfoliation of the epidermis and epidermal layer. Also, the germs that live, bacteria live on our skin, especially Propionbacterium. All this leads to formation of comedons, inflammation, and acne rashes. How you can distinct that this acne is non-acne vulgaris, but acne related to PCOS. First is non-responsiveness to conventional therapy. Second, you reveal the hyperandrogenemia in the blood test, for example. Then those women have irregular menstruation, so also one of the symptoms, and insulin resistance signs. Acanthosis nigricans. Acanthosis nigricans, it's an area of the skin with hyperpigmentation and verrucous appearance of the skin, usually in the groins, armpits, under the breasts, and inside the thighs. Around 5 to 10 women may report, and it happens due to insulin resistance mostly. So the acne vulgaris you can see not only in women with PCOS, those with diabetes and other diseases. Alopecia. Alopecia is a progressive loss and thinning of the hair, which is happening due to hyperandrogenemia, hyperproduction of DHT, dihydrotestosterone, due to hyperactivity of the 5-alpha reductase enzyme in this patient, the one that catalyzes reaction of conversion testosterone to DHT, dihydrotestosterone. So also those patients have short anagen phase and hair thinning get thin and become like a villous hair, and eventually it ends up with hair loss, alopecia. So all these effects of excessive androgen effects, as well as seborrhea. Seborrhea is a oily and glowing skin on the forehead, on the nasolabial areas on the face, and behind the ears. Laboratory diagnostics of polycystic ovary syndrome. So what range of hormones and other parameters, blood parameters you should evaluate. Of course, it's a testosterone total and free. Androstenedione, dihydroepiandrosterone and dihydroepiandrosterone sulfate, luteinizing hormone, follicle stimulating hormone, thyroid stimulating hormone, prolactin, 17-hydroxyprogesterone, cortisol, aldosterone probably, adrenocorticotropic hormone also, if possible, should be evaluated, C-peptide and insulin, and heavy metal testing. Insulin resistance can be also revealed with the help of glucose tolerance test. This is the criteria for metabolic syndrome in women with polycystic ovaries. So we're supposed to see the abdominal type of the obesity, the waist measurement 88 centimeters and above. You're supposed to see hypertriglyceridemia, increased level of HDL-C, blood pressure above 130/85, and hyperglycemia. Psychological impact. As I mentioned before, those women present with the symptoms of depression and anxiety. But this range is way more wide. Include the sleep disturbances, include psychoemotional fluctuations, and mood swings, and all in all, up to addictions development such as alcohol abuse, nicotine abuse. So this quite this part, or how you call it, these symptoms quite ignored by the specialist, but also need to be addressed, and those women should be diagnosed for PCOS, for hormonal imbalances such as PCOS. Conventional therapy of polycystic ovary syndrome. First of all, it's a use of clomiphene citrate and aromatase inhibitors such as letrozole to induce ovulation in case if those women present with infertility or subfertility problem. The use of glucocorticoids, the use of metformin, but metformin now is a part of also regenerative medicine treatment, which is quite successful. The use of hormonal contraceptives and other anti-androgens to reduce the symptoms of hyperandrogenemia, including the aesthetic part and all. But it's quite debatable, to the use of hormonal contraceptives and other. As I mentioned, one of the mainstream treatment, and including regenerative medicine treatment, is the metformin, the AMPK pathway stimulator, which is also considered as metabolic remedy. I mean, to address the metabolic syndrome problems, to reduce the weight, anti-diabetic drug. And longevity, also remedy longevity. The way how you prescribe metformin for women with PCOS can be quick, can be slow, but preferred, of course, slow route due to lessen of side effects. Side effects, it's a nausea, it's a vomit, it's a bloating, diarrhea. But if you use the slow route, such as first week 250 milligrams once a day, second week 250 twice a day, then thrice, then you increase after 1 week, then you increase to 500 twice a day, and eventually you end up with 2 grams per day, this dosage, and you maintain it. There is no cutoff, or there is no limitation for how long you should take metformin. It can be even prescribed to women, to pregnant women. It's safe for pregnant women. And in the studies was revealed that it helps to reduce the amount of miscarriages in the first 12 weeks. So those women with insulin resistance, with PCOS, who manage to conceive, no matter naturally or with the help of some technologies or treatment with clomiphene or whatever, so they still should resume metformin therapy during pregnancy. Lifestyle modifications. Of course, the reduction of the weight and maintenance of weight is number one, what you should do. Number one modality what's supposed to be used. The reduction of weight, 5 to 15% at least of the initial weight, helps to restore ovulation, to balance the hormones to normal. and to conceive even in a natural way. Those cases are quite common. Increase in the physical activity, regular physical activity, also supposed to be implemented. And stress management techniques practicing, such as yoga, breathing techniques, cognitive behavioral therapy, also mindfulness practices, and all in all. Detoxification helps to reduce inflammation, which is inevitable or always accompany insulin resistance, metabolic syndrome, and obesity, high level of inflammation. So you can reduce it with the help of detox methods such as chelation, essential phospholipids, which is our plug X, for example, with the use infrared sauna, hydrocolonotherapy, and other methods available. Herbal remedies. It's also quite big list, but among all of the mentioned herbs, I would like to emphasize myo-N-dichiro-inositol. Inositol, actually, it's a vitamin B8, but it's not known as a vitamin, more as a supplement or bioactive substance. So nowadays, it gives very good results in terms of addressing hyperandrogenemia. So there are available supplements of combined myo and dichiro-inositol in the ratio 40:1, which is also quite principle, this ratio. And using it 6 months and above helps to women to reduce in a safe way, without any side effects, to reduce the excess of the androgens, to reduce androgens to normal, restore ovulation, and also successfully conceive. Those cases known and I have had in my practice. Use of Gymnema. Gymnema sylvestre is also very good herb to address insulin resistance. And for example, those who have diabetes, also it works perfectly. Chastberries or Vitis agnus castus, I also like it very much because it helps to promote progesterone production in women of reproductive age and restore ovulation, restore normal cycle, and finally to conceive for those who plan it. Fenugreek seed also is very good to help with the cysts, if there are multiple cysts due to polycystic ovary syndrome on the ovaries. So fenugreek seed is #1 to reduce and prevent. Vitamin D3. Vitamin D3 works anti-inflammatory, antioxidant. It helps to normalize the activity of all the enzymes, and it stimulates and modulates normal steroidogenesis, so leading to normal production of the androgens. Quercetin, the same anti-inflammatory, antioxidant, restoring the insulin sensitivity of the cells. Mesenchymal stem cells. Mesenchymal stem cells and exosomes deriving from the mesenchymal stem cells. Also in the studies, it was proven that they help to restore normal ovulation and hormonal balance, to reduce the androgen excess. Organ-specific stem cells, the one, for example, that we use in our practice, xenogeneic, hypothalamus, adrenal glands, pituitary, ovaries, but ovaries that should be careful and not always. If, for example, you have androgen excess and women with diagnosis of polycystic ovary syndrome, and there are also the signs of hyperestrogenemia or endometrioid cysts. So those women with ovaries cannot be prescribed. we have very good combination mitochondrial peptides, LPP as IM key dose for this is good for people with metabolic syndrome, with diabetes type 2, and also for women with polycystic ovary syndrome and insulin resistance. This include peptides from liver, placenta, pancreas, stomach, intestinal mucosa, kidney, and eye, administered 1 vial 3 times a week for course duration 16 to 20 weeks. Vitamin D3, yeah, just now already I mentioned, and there is a publication proving so. It helps to modulate and normalize the production of the steroid hormones, mainly the androgens. The effects I'm also already I mentioned is anti-inflammatory and increase the levels of anti-inflammatory cytokines. Quercetin helps to ameliorate hyperandrogenemia, improves the follicular genesis, suppresses the insulin resistance, reduces testosterone. Supposed to be taken in dosage 1000 daily for 12 weeks. Quercetin. Quercetin we have in our also well-known and quite popular MCE Evo, PE Evo soft gels. Other vitamins and nutrients that's supposed to be maintained in a women with polycystic ovary syndrome: magnesium and acetylcysteine, vitamin B12, zinc, inositols already I mentioned, omega-3 fatty acids, berberine is very good, and chromium. Chromium also helps to normalize insulin metabolism and to tackle insulin resistance, to restore normal production to restore normal glucose metabolism, yeah, sensitivity cells to the insulin. Sometimes women present with excessive weight and with cravings, for example, for carbohydrates, I mean for sweet food, and quite common that they are deficient in the chromium. You prescribe chromium picolinate, for example, for 2-3 months, cravings gone, and this woman can successfully to reduce weight. Yeah. Mesenchymal stem cells, also already I mentioned, they help to downregulate the expression of pro-inflammatory factors in the stroma of the ovaries, such as tumor necrosis factor alpha, interleukin-1 beta, and interferon gamma. It was revealed in the study in the article that I have attached. It helps to normalize local and systemic immune effects, such as ratio of the macrophage, reduce the amount of M1 macrophage and to increase the amount of good M2 macrophage, which also quite important, and the amount of regulatory T cells. Organ-specific stem cells, already the one I mentioned, just the picture, the one that regulate hypothalamo-pituitary-adrenal axis, also can be used to treat women with PCOS, to normalize the menstrual cycle and production of the hormones. Thank you so much for your attention. If you have any questions, I'm open to address the question. Thank you.